I do not have any financial disclosures in regard to this presentation. This is a case of a 6-year-old woman who was referred to me with complaints of intermittent right-sided weakness thought to be due to TIAs. The MRI of her brain did not reveal any prior evidence of stroke. She had both carotid duplex imaging and a magnetic resonance angiogram, which suggested severe left internal carotid artery stenosis. She was thought to be at high risk for carotid endarterectomy. This was a procedure I performed about 2 years ago before the Medicare payment guidelines changed. And it was high risk because of her severe home oxygen dependent COPD. So she was referred to me for carotid artery stenting. Her past medical history is basically most remarkable for her home oxygen dependent COPD, her renal insufficiency, and her supermorbid obesity, which is very common where I practice in Oklahoma. She had a BMI of 45. And on physical exam, this was most remarkable for her left carotid bruit and the obesity of her neck. Not to sound mean, but basically her head just tapers down to her shoulders, and there's really not a neck. So this was the start of my diagnostic procedure. I always start with an arch shot. She does have a bovine aortic arch, which, in case there's any in the audience who aren't familiar with this, basically the left common carotid artery originates off of the brachiocephalic artery. Although it's type 1 angulation, in this particular case, there's a severe turn, about 180 degrees, going into that left common carotid artery from a transfemoral approach. I always shoot the opposite side. The right internal carotid artery just had mild luminal regularities. The right-sided cerebral angiogram was fairly unremarkable. To engage the left common carotid artery, I did have to utilize a Simmons 2 catheter, which I always prefer to form in the left subclavian artery rather than doing helicopter spins in the aortic arch where I might dislodge some plaque and cause a stroke. We selected the left common with that Simmons 2, and it confirmed the severe stenosis of the left internal carotid artery. Cerebral angiograms on the left side were fairly unremarkable. She was noted to have a persistent left posterior cerebral artery, which you'll see here. So at this point I paused because of the complexity of the arch and also because of her renal insufficiency. I decided that I should probably stage this intervention rather than jumping straight into it. And the more I thought about it, rather than coming transfemoral through the aorta and trying to navigate this reverse turn into the left common carotid artery, I decided in this case the most straightforward approach would be to come transradial to get into that left common carotid artery with our interventional equipment. So we placed a slender sheath in the right wrist. I used a 5 French diagnostic IM catheter to engage the left common carotid artery. At this point, I was able to advance a glide advantage wire into the left external carotid artery. Over that artery, I exchanged out our system for a 6 French shuttle sheath, the tip of which was placed in the mid portion of the left common carotid artery. At this point, I advanced a coarse Xi'an blue guide wire into the left internal carotid artery just around this Pietrus curve. Over that wire, I advanced a Spider 6mm distal embolic protection device and deployed that just below the Pietrus curve of the left internal carotid artery. Working over the spider wire, I pre-dilated with a 4/0/30 angioplasty balloon. We then deployed a tapered 10-7/40mm dedicated carotid stent. That stent was post-dilated using a 5/0/30mm angioplasty balloon. The angiogram post-intervention showed a very good result at the intervention site. We retrieved our spider without any difficulties. The repeat angiogram after retrieving the spider confirmed the good result. I always recheck my cerebral shots at the end of the intervention, and there was no change in the angiographic appearance of our cerebral vasculature. Patient was discharged home the following day. In conclusion, percutaneous carotid artery stenting still plays a major role in the management of patients with carotid artery disease. Complex aortic arch anatomies can make transfemoral carotid artery stenting more challenging. Anytime more challenging, it will be more risky for the patient. A transradial approach can often be used to overcome complex aortic arch anatomies to facilitate carotid artery stenting. Further technological advancements are likely to expand the role for transradial carotid artery stenting in the coming years, at least I hope so. These advancements will allow skilled providers to offer patients with severe carotid artery disease the most minimally invasive approach to achieve carotid artery revascularization. Thanks.